Thanks, Mr. Chairman. After the nice presentation of Professor Mario from Pittsburgh, I will show you in a few minutes, some details of the special care with the robotic Whipple. There is no conflict of interest, no disclosure. Which surgeon has qualification to do this procedure with minimal complication? More than 25 surgeries a year, experience of more than 300 pancreatectomies, and mortality much less than below 5%. Competence to avoid pitfalls. In my hospital, Albert Einstein, we are a big center of the referral from all Latin America, so we are able to treat a lot of pancreatic cancer. But they are changing the treatment of this patient because the great oncologist group are doing neoadjuvant therapy in most of the cases of pancreatic cancer, adenocarcinoma of the head or of the body of the pancreas. So much more patients now are submitted to neoadjuvant treatment with the sulfoxide, and if the sulfoxide doesn't help the patient, they introduce gemcitabine and taxano. Minimally invasive versus open surgery, all over the country, all over the world. Same results. Robotic has better quality of life, and like Professor Giulianotti and Professor Kendrick demonstrated, minimally invasive guarantee to the patient more quickly to the adjuvant therapy if it's necessary, not to demand too long period to recover. The problem of the surgery is the bleeding postoperative period. Like Professor Giulianotti said in all these speeches, all named vessels must be ligated, stapled, or clipped. Not seal named vessels, never. Bleeding in postoperative period means inferior pancreatic duodenal artery or gastroduodenal artery, most of the cases. And how to avoid fistula? It's a major complication. You see a lot of presentations, very nice today. You can use various a lot of numbers of gastric and pancreatic reconstruction with the jejunum, with the stomach. But in cases more complicated, I prefer to drain through the bowel and put the drain out, like Howard did in 1980s. And for very tender pancreas, I do this type of anastomosis. It's very nice for the tender pancreas with a very thin duct. The Akihiro Shoyu. It's invaginating anastomosis. I did 15 cases since the last Congress, October last year. And it's very precise and very good to do with the robo. It's a very interesting method for the pancreas thinning. You can put it into the stomach, or you can do the Akihiro Shoyu anastomosis. When the duct is dilated in the pancreas, it's hard, no big trouble. You can do whatever you want, but I prefer a modified Blungart like Professor Anuzaki told us 1 year ago. It's a very nice procedure, very easy to do with the robo. And there is specific cases I never do robotic yet. In cases like this, a young man with extensive neuroendocrine cancer, we did a vascular resection of the mesenteric artery with terminal anastomosis. We did total pancreatectomy to avoid fistula, and it was a very huge mass from the tail to the head of the pancreas. And we put a very interesting graft made with the peritoneum. I make a graft with the mesothelial surface of the peritoneum. It's easy because peritoneum is beside the operative field, too easy to do. And it's very interesting. This patient was operated 1 year and a half ago, and the graft is very good. I don't like grafts, synthetic grafts in this position, because if the patient lives more than 1 year and a half, 2 years, the graft will obstruct. Care with the postoperative management. Caution with IV solutions. Intensive care units all over the world give too much solution IV to our patients. And the patients could develop edema of the anastomosis. The patients could develop paralytic ileus. No advantage to the early parenteral or enteral nutrition. You can give it to the patient, like Professor Mario showed, liquid in the first postoperative day, and then in fourth postoperative day, you can introduce normal diet. If the patient has pancreatic fistula, parenteral nutrition. When you are able not to drain the abdominal cavity based in the statistical analysis. In heart pancreas, no bleeding during surgery, no transfusion, and dilated Wirsung. Then, if you are able to do a very precise anastomosis, you don't need to use drains. Drains are not good for pancreatic surgery, like people of Verona teach us, like people of Massachusetts General Hospital teach us, and everyone. When you remove the drain, in first PO, you do the amylase of the drain. Less than 5,000, this is the cutoff. Consider the removal of the drain in the next day or after the next day. 3 postoperative day to 5 postoperative day. Only the surgeon removes the drain. Why? Because you have this amylase level really low. You need to see how is the aspect of the fluid. If it is clear or serosanguineous clear, you can remove it confident the drain. But if the drain develop a brown color, black color, or most hemorrhagic drain, you are able to remove the drain. So the surgeon needs to do the aspect of drainage to permit the removal of the drain. And about the bleeding, the most feared complication in this surgery. Immediate arteriography. Most of the cases, gastroduodenal or splenic artery, it depends on the type of the surgery, you need to do surgery. Pancreatic duodenal artery, it's possible to embolizate. In doubt, operate the patient, reoperate the patient to seal the vessels or to suture the vessel. But with the robo, with the most precise dissection, and with the increased experience of the surgeon, he's an outlier, we are seeing almost less bleeding than before. Thank you, sir.